All right, and I will hand over to Catherine to start with our introductions.
Awesome. Thanks so much, Amanda. And hello, everyone. Good afternoon. So I think we actually wanted to kick off a little bit of just a poll with folks just to ask you a couple questions. And so Amanda, I might get you to, if you are able to launch that poll.
Sure, can you see that now, Catherine?
Yeah, I can see it, and I'm hoping folks are able to answer the questions. We just want to get a sense of, if you've attended these OHT Lunch and Learns with us before, and then also ask you around a question about whether or not you've heard about community paramedicine before. And if folks are able to answer that poll, that'd be great. And Amanda, let me know as answers start popping into your way.
Sure, I think we have about half of people have answered so far. Just
Amazing.
give them a couple seconds to read and then we'll end the poll. All right, I think answers are slowing down, so I will end that for us. And hopefully you have the results up there.
We do. I can see the results, and that's great. It sounds like, so we're at almost about a 50-50, well, not 50-50, but just a little bit over folks have joined us previously, but we've got a lot of new people joining us today. So welcome. I hope that this Lunch and Learn is enjoyable and informative. And then in terms of people's knowledge around community paramedicine, so yes, so lots of folks know about community paramedicine or at least heard about them, but might not know the details today. So we'll definitely get into that then. Thanks so much for that, Amanda. So if you wanted to advance the slide, we can start and kick things off. Before we do move ahead and I hand things over to Chris and Autumn, I do want to just sort of say, start us off with just a brief overview of the OHT. We are a collaboration of health and social service providers, including primary care, hospitals, community care, community paramedics you'll be hearing about today, working together to create a system of integrated care for our population.
I just got to get out of my one.
I just ask folks to please mute. Oh, there we go. Great, thank you. So we are, again, working together to create a system of integrated care for our population. And this work is really done through the lens of we're taking a lens of health equity to make sure that the needs of our local community are reflected in the work that we're doing and that there's equitable access to care and services for everyone in the Kawartha Lakes and Haliburton. Since the fall of 2022, our work is focused on advancing integrated care by building clinical pathways for heart failure, chronic obstructive pulmonary disease, palliative care, and mental health and addictions, all with the aim to ensure seamless transitions across the continuum of care. So as a person moves from hospital to community and primary care. A key enabler of this work is advancing digital health, we know, which at maturity will enable care providers across our system to share information more efficiently and effectively, easing the transitions in care for patients and really enabling patients and providers and caregivers to access health records and care plans and ultimately enhance system navigation. A third component of our work, in an area that we'll be focusing a lot of our efforts on over the coming year, is engagement with our partners. In particular, primary care is the foundation of an integrated system, as well as an engagement with the local community, patients, family, and caregivers. So with that said, it is my great pleasure to turn things over to Autumn and Chris to introduce themselves and to take us through the incredible work that they do and the world of community paramedicine. So off to you.
Thanks, Catherine. Good afternoon, and thank you for joining the fourth Lunch and Learn that is being offered. I first would like to thank Catherine and Amanda, as well as Stephanie, for the opportunity to share the world of community paramedicine with all of you, and hopefully answer any questions that you may have about it, what we do, and how we differ from the operational 911 paramedicine. My name's Autumn Campbell, and I'm very honored to introduce myself as the Superintendent of Community Paramedicine for the City of Kawartha Lakes. I've worked in paramedicine for almost 20 years, with 6 in a supervisory role and the last 2.5 years in the community paramedicine supervisory role. I am an advanced care paramedic by training, but I love the challenges, wins, and opportunities the world of community paramedicines offer. I didn't see Chris's name on the participants. Is he here?
I think he's just having some technical issues.
Okay.
So we'll just hopefully he'll be able to tag in soon.
Yeah. So we'll give him maybe a minute or two, but I can introduce Chris as well.
Perfect.
Chris Parrish is the commander of clinical programming in Haliburton County since 2021. He has 33 years on as a primary care paramedic, and he's been in the role of the portfolio of community paramedicine since 2017. So we can move to the next slide. Give Chris another minute or two there to hop on. The agenda that we have on the table for you today is on the screen, and we will tell you a little bit about each history of community paramedicine, both in Haliburton and Kawartha Lakes, an overview of the services that we offer as they may differ, as well as the structuring of our programs, our demographics of the patients we serve, and a few of our success stories. Probably for some of you on here, it's the important part, how to make a referral to community paramedicine, and then we'll have some time for some questions at the end. We are hopeful by the end of today's session, you will have a better understanding of the CP world, who we are, what we do, and how we can help you and our community. Next slide. And we can go on to the next slide as well. Amanda, please. So Kawartha Lakes Community Paramedic Program, we had a very unique start to our program. After many funding attempts through government grants and various grants, a need for such a program was recognized by our municipality. We were funded through the municipality, which is very unusual for the first 3 months of our programming, while other opportunities for funding was still looked for. This 3-month term allowed us to fund one full-time community paramedic, which is, I'm sure many of you on the call know, was Julie Milne. Julie is still with us, and we are so thankful that she joined us at the initial stage. Fast forward 3 months, we still had no funding from any grants or provincial levels of government. So the city saw further value and need for community paramedicine, and funding for the program was added again. Fast forward another few months, and we had another partnership formed, and I would be remiss if I did not thank our partners at the Ross Memorial Hospital for a collaborative opportunity to fund the next period of time in our community paramedicine history. At the end of all this period, which was probably the better part of a year, the government initiated funding provincially for community paramedicine. This funding allowed 52 services across the province to provide services to fill in any gaps that were being missed by other healthcare providers or agencies. Next slide was Chris able to get on?
I think he's still sort of having trouble, so we might have you continue on if that's okay, Otto.
Yeah, I can read Chris's slide. I'm sorry, I can't really speak much more than what's on the slide. Apologies for that. But Haliburton started a little bit earlier than Kawartha Lakes. They received funding for one community paramedic, to be embedded with the HHHS GAIN team up in Haliburton. They continued with this model and expanded to accept clients from other organizations as the program grew and gained recognition up in Haliburton County. In March 2021, they very similarly, like Kawartha Lakes, received funding through CPLTC. So it was just the funding stream that the government classified it as to expand the community paramedic program. In October of 2021, the commander of clinical programs was hired, which is Chris, along with 3 temporary full-time community paramedics. And that funding was till the end of March 31st, 2024. Base funding was secured, and the county agreed to fund one full-time community paramedic if provincial funding dates dry up. CPLTC funding is extended until March 31st, 2026, and the original contracts ended and are reissued. I know Chris would better speak to this, but he was very happy last week when I was with him at a conference to say that they were actually have their own base now. So they were able to find some rental space for the CP team up in Halliburton and now have their own base. So he was very excited about that. So next slide, Amanda. So as I alluded to, there's two streams of funding. It's very important to know that all CP programs run and operate differently, allowing flexibility for local needs, and most importantly, without duplication of services that are already being offered or provided. The primary goal of all community paramedic programs is ED diversion, or in very, very simple terms, trying to help our hospital partners by keeping lower acuity patients out of the emergency department. There are two streams of funding. One is referred to as the CPLTC stream, and this encompasses our aged or aging population, those who are eligible or soon to be eligible for long-term care, those with specific circumstances or conditions that would benefit from the CPLTC service to avoid hospitalization, increase quality of life, reduce waitlist burden, and give peace of mind not only to the patient, primary care providers, but as well as their loved ones at home. The second stream is referred to as expanding community paramedicine. This funding is looking at helping with the 911 call volume as well as ED diversion. The main population in this funding stream in Kawartha Lakes are those in our community who struggle with substance use, mental health, being unhoused, so our most vulnerable at-risk population. This stream also helped during COVID fund surge management. So this team was out in our communities providing swabbing as well as vaccinations, which we still do to this day. And we aid the health unit in providing, as I said, the influenza vaccines as well as COVID boosters. Next slide. Is he on?
Yeah, he's here. Take it away, Chris.
It's all you, Chris.
All this technology and I'm on my phone. I think, yeah, simply put, we do our best to keep frail, elderly, seniors safe in their home as they age. We do that primarily through in-person visits, which we do 400 to 500 a month. We do a little bit of remote monitoring, which will expand with the CHF directives. We work closely with the GAIN team, which is where we came from. I think Autumn gave a little history there, but we continue to work with them and see a lot of their patients, kind of the eyes on. We get most of our referrals for home and community care support services, hospital discharge and primary care, and we pick extras up through other agencies. And we also work backwards. We'll make referrals to GAIN with patients that we've been referred to, Meals on Wheels and mental health. Our funding, basically, the long-term care clients, or the ones that we keep on long-term care, are funded through the CPLTC stream. The ones like hospital discharges and that come and go more quickly, we use the Ontario Health funding for that. Next slide.
So Kawartha Lakes is extremely fortunate to have 8 full-time community paramedics on our team. All 8 are at minimum AIV certified, which means autonomous IV. This allows members of our team to initiate intravenous access to provide fluids or medications. Our team has also received phlebotomy training, which allows us to draw blood directly from the patient to help us with clinical decisions regarding care and treatment within the homes of the patients, hopefully avoiding the need to access the 911 system and once again, the emergency department. As we've already said, we have funding until the end of government fiscal, and the support from the government allows not only for future expansion, as well as training opportunities to better serve and address the gaps in our local community when it comes to care. Next slide. We provide support in our community 7 days a week. Our team is fortunate enough to have the same group of patients, which means that they have the same rostered patients every day, which allows them to build trust and a true care plan within the community. If that community paramedic is ill or off on vacation, we are still able to support their client base. We just redistribute it amongst the rest of the team, once again ensuring that individuals are not falling through the cracks, and as well as continuing additional support in the community.
So we're staffed 2 community paramedics every day, most days. Today we lost one to the 911 side. Most of ours are AIV as well, 12 hours a day, 7 days a week. On Tuesdays, we run a third CP and they go to community outreach, and then they'll do vaccines and general catch up on anyone we've missed in the last week. We have no supervisors or no administrative support. It's just us. So. And we're staffed 8 in the morning till 8 at night, 7 days a week, usually. So yeah, our overview of service, primarily, as I said, it's in-person visits. I think it's important to get eyes on people. What they tell you on the phone and what is actually going on are 2 different things. And when we see a person, we're doing home safety checks, falls risk assessment, medication compliance, a physical assessment, including vital signs, and we're looking for the availability of safe and nutritious food. Some patients are remote monitored. Usually this is, diabetics or hypertension, that they've had a change in medication. So we'll monitor it that way. We do COVID vaccines. Search has really, they donate as many meals as we want, really, every month, and we'll deliver those to clients at risk. And we make referrals to GAIN Mental Health Community Support Service as needed.
I recognize that this is a very busy slide, but this is just kind of an overview of the services the Kawartha Lakes team provides. We, at the core of our program is the home visit, very similarly to what Chris said. During this time, we take individuals' vitals, address medication compliance, any potential safety risks and hazards within the home, as well as any ongoing chronic conditions. We also work with the patient's primary care practitioners, advocate for the patients with referrals to other community partners. Navigation through the healthcare system is difficult enough when you know what resources are available. But when you are not sure what is available or how to navigate the system, our community paramedics can help with this as well. We currently work with a physician who has approved and oversees approximately 15 medical guidelines. These can include a temporary adjustment of a medication such as Lasix during exacerbation in order to avoid a visit to the emergency department, or supportive care for acute nausea or pain. The community paramedics are able to make clinical decisions within these guidelines and to help individuals that are rostered within the program. The support of chronic health conditions is a huge piece of our program. And we work with local educators, physicians, and clinics to ensure that individuals are supported where we can also accomplish this goal is with the addition of our remote patient monitoring, which allows a community paramedic to monitor a self-directed vital gathering, and which will contact the patient if the reports are outside their normal limits. We offer in-home support and vaccinations in partnership with our local health unit. This is for those individuals who cannot leave their home. We have the ability to vaccinate for influenza, COVID-19, as well as a variety of other injections. We have partnerships with our hospice and palliative care team to ensure that those who are end of life are appropriately supported as well. Our CP team has been offering clinics for the better part of a year at high utilization buildings. These are offered for those both experiencing substance use and homelessness, as well as our seniors population. The ideas behind these clinics is that we address the needs of these populations, as they can easily fall through the crack, and hopefully once again avoid the need for 911 or transport to the ED. Next slide. If you had asked community paramedicine programs 3 years ago about capacity and what was manageable and for a community paramedicine program, the ideal number would have been 1 community paramedic to about 50 patients. Unfortunately, or fortunately, however you look at it, that's no longer the case. The program has had such a success and have had so many success stories. The Kawartha team is supporting over 650 patients currently, not including those who are unhoused or who visit our clinics. The ratio is approximately 1 community paramedic to at least 80 patients. As stated before, some of these numbers are supported through remote patient monitoring, as well as clinic type settings. The clinics allow the community paramedics to see multiple patients and provide care in a shortened period of time without the additional time of traveling home to home. Next slide.
In Halliburton, currently we have just over 200 clients rostered. We'll do about 400 to 500 in-person visits per month. And yeah, we throw in the clinics as well, which are nowhere near as big as Kawartha Lakes, but we probably see 10 or 12 people once a week at these clinics. And yeah, we're we're at capacity for sure.
So future expansion of the community paramedicine program, the possibilities are honestly endless. The expansion possibilities are truly dependent on community partners, capacity of the team, as well as approval by our medical director. Other CP teams in the Eastern working groups are supporting post-surgical hospital discharge with ultrasounds and overnight visits, allowing patients to leave the hospital earlier and recover at home with support. It is extremely important to note, again, that community paramedics are not trying to duplicate or take work away from anybody or from another agency. There's enough work for all of us, but we try to fill the gaps until those agencies can respond or be better in place, which at that time, the community paramedicine program will remove their care if appropriate. Expansion is also planned more into our vulnerable populations, supporting those with housing insecurity, substance use, and experiencing challenges with mental health. Truly, the sky's the limit for community paramedicine. Next slide. So Chris and I are going to share a couple of success stories with you, and just tell you a few of the individuals that we have impacted or our teams have impacted. Next slide. The first story I would like to share is one of an elderly lady who lives alone, extreme visual impairment with no supports and no family. To emphasize the lack of supports this individual has, a lawyer is her POA. Patient was initially brought to the attention of the CP team by an operational paramedic who had attended her home for anxiety and shortness of breath. The CP initiated a visit and found the patient to have an irregular heartbeat, shortness of breath, and crackles in her lungs. A connection was made for this patient to a cardiologist who found that the individual was both in kidney and heart failure. New medications were started as well as further investigations, ultimately finding a poor ejection fraction. Further connections were then made for this patient by the CP to cardiac failure clinic. RPM was placed in her home and for monitoring of vitals. The continuous education, comfort, and support that the CP has provided this patient was paramount in aiding her to stay within her home, regain her health, stay supported and connected. As a side note, her ejection fraction has remarkably improved, so has her kidney function. This lady is an amazing lady, and if she was on this call right now, would not be able to say enough about her community paramedic. But I truly feel that she is one of our very first success stories and very worth sharing. Chris, do you want to go next or do you want me to go?
You can carry on if you want.
Sure. Another story I'd like to share is one of a 56-year-old under-resourced male. This patient thought he was medically stable and had not been to his primary care in quite some time, thinking he was medically stable, obviously not aware of his underlying medical conditions. This is a gentleman that we actually experienced in our outreach clinics. The patient initially came in for free subs, which was how we initially started our clinics to entice our vulnerable and our unhoused into care. Once he became comfortable enough with us, he consented to an assessment. The patient was found to be extremely hypertensive with an irregular heart rate. We sent a report to his family doctor, whom the patient, as I said, had not been seen for quite some time. The doctor was extremely responsive and immediately ordered a Holter monitor for this patient, as well as some blood pressure medications. After the results came back, the patient was diagnosed with AFib, atrial fibrillation, sorry. Patient is now on blood pressure medications and a blood thinner, without having to make or attend a doctor's appointment, just based on the assessments made by our community paramedic team. Patient checks in with the team each clinic now that we're at in his building. And after a few weeks on medications, he's now in normal range for both his heart rate and his blood pressure. Because of this assessment, he was able to greatly reduce his stroke risk factors. He's very grateful and has convinced others in his building to come down for assessment. I actually had the privilege of meeting this man just a few weeks ago when I attended clinic with our team, and he could not stop raving about how the team saved his life. The collaborative efforts of the CTP team, as well as the trust that was built with this gentleman and the team, ensured that he received care without barriers. And Chris, I think it's your turn.
My turn.
Yep.
I think two stories to share. One, I mean, the first one just kind of shows how it's a community-based program, but we received a call from Andrew Hudson about somebody living in a car. Wondered if we could assess him. So I took the behavioral support worker from Gain, and we headed up and we assessed him. She was questioning dementia. His blood pressure was through the roof. So we continued to follow him. He was able to get housing. Continued to follow him, keep an eye on his blood pressure, keep an eye on, that he was taking his meds. It was found out later that he'd actually suffered a cardiac arrest. So it wasn't dementia per se, more of acquired brain injury from that episode. We continued to follow him. During COVID, we actually would go in with our iPads and remote in with this cardiologist. We would do the assessment, do 12 and 15 leads, etc., and with the doctor online with us, and that worked. And we followed him probably for 2 years. Things started to go downhill. He started to smoke in his community housing building, which didn't go over too well, but it was he couldn't correct it because he honestly couldn't remember that he wasn't supposed to smoke. And he was moved down to Lindsay. I'm not sure where, but there's a facility where he can smoke outside. I don't know if you happen to know Adam or not. But
I don't know. We could talk after.
Yeah, but like we probably for 3 years we had him as a patient, and between housing and mental health and Gain and community paramedicine, we were able to really keep him fairly safe in the community. He was prone to giving his money away to people who asked for it, so that was a big problem. But anyway, everyone loved visiting this guy, so he was a good patient that way. But and the other one was the height of COVID. Gain had assessed a patient, and we're pretty sure he had Parkinson's, but neurologists weren't seeing patients. So again, we went out with our iPad. Our vehicles have the ability to, they have Wi-Fi in them. So we hooked in through our vehicle, and the neurologist came online with us. It was a good learning thing for us. We were able to do all the assessments, physical assessments for the doctor. And the doctor said that the first drug for treating this is called a beta blocker. However, I'd done his vitals before I got there. His heart rate was in the low 50s and his blood pressure was very low. So the last thing he needed was a pill that was going to slow his heart rate and drop his blood pressure. So I think it was a good catch. Had he just gone to the office, been prescribed the medication and gone home, I think it would have been a call for the ambulance when the medication kicked in. So I think I think Autumn touched on it too, but during COVID, we never stopped. We continued to see all our patients and then some. And, up here, particularly, we were the only people that these people were seeing for probably 2 years. Anyway, that's our stories. And then how to make a referral. I think both North Lakes and us and most of Eastern Ontario are on CareDove.
Yeah. So there's multiple ways to make a referral to community paramedic programs, as Chris has said. We accept referrals from our community partners directly, as well as through CareDove. CareDove, for those who may not be familiar, is a secure bi-directional communication referral platform. And if you already have a CareDove site, you are good to go, and you just refer to the community paramedic program through there. However, if you don't, there's another way you can accomplish the same goal to submit a referral. If you were to go to www.communityparamedics.ca, you can submit a referral. The website is unique, as this website is all the Eastern community paramedic programs all on one page. All you need to do is scroll down, click healthcare referral, type in the address of the home you wish a CP to come visit, and then on the left-hand side, as you scroll the page, it will actually take you to the right community paramedic program to fill out that specific referral. As we know, this is an extremely important option, as we do border many other areas, and this will ensure that you are taken to the right programs page. So I know Chris and Peterborough and Northumberland, we often get many referrals for one another. So this alleviates that. We are also currently working on an ocean integration, which will allow primary care providers to refer directly through the CareDove platform as well, which makes it easier. We work so closely with our community partners, both in family practice as well as in the emergency setting. Primary care providers are able to refer to the program directly, and due to collaborative partnerships, do this on a regular basis, as well as our partners at the Ross Memorial, who refer from many different departments. We receive referrals from home and community care, who look for additional support services in the community. We support those with chronic illnesses, those who have challenged with medication compliance, fall risks, or those awaiting movement into long-term care, and those who are hoping to remain in their home as they age with additional supports. Next slide. So the Kawartha Lakes CP team has been very, very busy taking education and gaining more skills. I don't let them rest, but they're on board for it. So we've been trained in seniors' mental health, chronic health conditions, geriatric specific health, as this is our main demographic. As I stated already, we're AIB certified at a minimum, which, as I said, allows us to do training into our phlebotomy, which we just obtained the latter part of last year. You may be wondering why we need phlebotomy and AIB education, but this allows us to provide blood testing within the home in order to support our medical guidelines and directives. Our directives have been developed in collaboration with a local physician, which allows us to further support those on our roster. The last current education that the team is currently in the process of obtaining is our wound care training. By no means will we be wound care experts, by no means. But once again, we will have gained a better understanding of wounds, the care, and how we can support and refer, as well as help people in our community. It is important to note that each community paramedic program may differ in their education and ultimately the services that we offer. This is mainly due to the localized community need, and the needs of those in Kawartha Lakes will greatly differ from those needs in Haliburton, as well as those in more urban centers such as Toronto or Hamilton. Chris, did you want to add anything there?
Sorry, I seem to disappear again.
No, that's okay.
I mean, we're on board and working towards where they are in Kawartha Lakes. Our staffing is done differently here, and like I said today, we lost one. Often we lose two. It's hard to get momentum going when you're doing that. And then we had a 2-year contract because the funding was for that 2 years, and we tried to extend that contract. Grievance was filed, that was stopped, so we had to rebid for all the positions. So we'll be starting again March 31st with a whole new team. Well, one original, but the rest will be all new. So it's been hard because, I just didn't want to spend the money doing all the training for people who are possibly leaving in a month. So we've got our base, a place to work out of, and I think a good team now. So moving forward quickly with everything else on that list there. So
Next slide. So I and Chris, I'm sure he will echo this, are extremely proud of what our team has accomplished. Our CKL team has grown both in numbers, but as well as we've been able to develop support as well as add collaboration in our community. There are very few things that a community paramedic team will not support, or at least find a way to try to support. They are champions, advocates, caregivers, educated members of the healthcare community that are there to ensure that not only those in our community don't fall through the cracks, but they advocate for those in our community while they await care. Any questions about everything we've just let you know?
So if anyone has any questions, feel free to come off mute, or you can raise your hand or just pop it in the chat as well. We can answer them all that way.
I don't have a question, but just want to say an awesome shout out to Autumn and her team. I'm Sharon Yo, Manager of Hospice Services for Community Care City Kawartha Lakes, and they are just the best team to work with. Autumn attends our bi-weekly rounds, makes sure that none of our clients on our roster are falling through any cracks, and I'm just so thankful that we have this team, and that we're talking about expanding and what else can we do and how else can we support our community. So thank you so much, Autumn, and your team. And Chris, you're doing a great job up there in Haliburton. We're just not there, but you're doing a great job. Thank you so much.
Thanks, Sharon.
That is a glowing review. Thank you, Sharon. Something came in on the chat. I don't know. I think it's just about someone having a grouchy internet connection, so that's okay.
Sue and I are on the same connection, I think.
Yeah. I know, I see the dark clouds rolling in. I'm just like, hold on for another 5 minutes. Don't want to lose my internet. Catherine, did you have a question or a comment?
Yeah, I can ask a question, and I do want to thank Autumn and Chris for sharing all about the wonderful things of community paramedicine. When I first started my role in my work in the Kawartha Lakes and Haliburton, that was kind of a consistent message that I heard over and over again, was this bright light that community paramedicine was. And so I thank you for the work that you do. It's very clear the importance of partnerships in the work that you do. And I think the work that all of us do is, if we really think about integrated care, and I kind of wonder about what for each of you sort of see, what are the critical partnerships that you need to maybe enhance or grow in the next few months and years in terms of community paramedicine to really kind of enhance care?
I think I'll go first, Chris, if that's all right. I think with the demographic being very similar in both Kawartha and Haliburton, I think, and the fact that we are losing primary care practitioners, and they are hard to entice to more rural areas. I think the partnerships with our primary care is definitely utmost importance. And on the back half of that, our partnerships with our local hospitals. Some of these individuals have to go to hospital with no primary care, so they go in, they get treated, and they're left hanging. So that collaborative piece with the hospital is also very important. I think, unfortunately, as people are aging, there is a lot more need for partnerships with services like Sharon's palliative care and hospice, and we are able to support those as well. I just think that the primary care is really the piece we're missing, but I'm hoping with that integration piece with Ocean that elaborates. We do have some primary care champions, don't get me wrong, within the Kawartha Lakes world, but we still don't have that same collaborative or communication with all our primary cares. And I think that that's a goal for us anyways.
Yeah, I think we have, you know, it comes and goes. During COVID for sure. They were reaching out to us a lot. And I think kind of funding changed a bit too, so that dried up. But I think we gained some traction there. I mean, Stephanie probably heard this, but when the program started, one of the physicians actually called it a huge waste of money, but probably within 2 years was referring to us. So I think they saw the value in it. There's just, I don't know, the one-off things that we can do in the community that no one else will touch makes them reach out to us. But I do think the aging population, I think the funding is there. It's just getting the buy-in to doing it. Counties are reluctant to spend money that may dry up. So it's a very cautious approach to it. So I think that's kind of where we're at. We need the buy-in, you know, take the risk and assume the money will still be there, I guess. Easy for me to say, but that's where we struggle.
Thanks for that. Thanks for asking that question, Catherine. I know we have about 2 minutes left, and hope we can get this one last question in. Sue asked, can people make a self-referral?
So for Kawartha Lakes, sorry, I apologize. The short answer is no. In order to refer, you need a referral from your primary health practitioner or a physician of some or a collaborative partner service. So if you go to hospital, the GAIN team, the ARM team, that the ED can directly refer. But for Kawartha Lakes, no self referrals, unfortunately. Our capacity is just it's getting pretty tight. So if everybody was a self referral, we wouldn't be able to aid those that truly needed the support.
Yeah, I think our answer is pretty much the same. And not to say it doesn't happen. I'm sure it happens for Autumn as well. But the problem is reporting. So you go see somebody who's self-referred. They don't have a family physician. What do you do next? You've got them, you've assessed them, you've found some concerns, but you have no way to treat them. So not the best answer, but that's the way it is. So.
Thank you for asking the question. So I see we're at time. I think we can get ready to wrap up. We just want to let everyone know of our next Lunch and Learn that's coming up on March 27th. We'll send out sort of the registration link for that shortly. But this one will be just about the KLH-OHT 101, as we're calling it, to learn more about some of our programs and initiatives, just give an update on the things that we're working on. So I know about half of you have attended a session before. We hope to see you and everyone else there again. And we also do have all of our past Lunch and Learns recorded and saved on our website. So if you go to klhoht.ca/resources, you'll find all of the links to the previous ones. And if you do have any other questions for Chris or Autumn, you can feel free to send them to our email address there, info@klhoht.ca, or give us a call and we can share those there. But I want to thank everyone for joining us today. I don't know if Chris or Autumn or Catherine wanted to say any closing remarks.
No, just thank you for inviting us to talk about CP. It's an amazing world, and as I said, it's very fulfilling for our team, and I say it all the time. I'm just lucky enough to be able to run the background for them, so they can go out and do the work that they do. So,
well, hopefully, OHT will be another pathway for us.
Great. All right, well, thanks everyone. Enjoy the rest of the day, and we'll see you at our next Lunch and Learn.
have a great day, everyone.
Take care.